be paved with gold. Yeah. Hope my whole hood make it home. Yeah. May your streets be paved with gold. Yeah. Hope my whole hood make it home. Yeah. Cause the world can be toxic, especially when your skin look like chocolate. At one point they sold us for profit, but we made it out of the gauntlet we chosen. Yeah. Oh my mama, the south side still holding. Yeah. Go for broke for the ones that are broken. Yeah. Please don't make me no hashtag or slogan. My whole hood is golden. That's why I pray you catch a wave that doesn't subside. This for the nappy heads in heaven, with a nappy head Christ by their side. I pray you catch a wave that doesn't subside. This for the nappy heads in heaven, with a nappy head Christ by their side. Yeah.
All right, well, welcome everyone. It is so great to see you all. And we are so excited that you're joining us at our July Collaboratory focused on the dramatic impact of police violence has on the health of our communities of color and the health of birthing people within those communities. My name is Chanel Williams, and I'm the Director of Community Engagement and Partnerships at PTBI. We are so excited to have you with us. If this is your first event with the California Preterm Birth Initiative, we welcome you to join us every month at our Collaboratory series to think through and generate new ideas, collaborations, and innovative approaches to preventing preterm delivery and improving outcomes for babies born too soon. Today, we are honored to host Police Violence and Birth Outcomes, how policing in hospitals and communities impacts our health. When you joined, we had a poll asking how you identified and where you're calling in from. So thank you for participating. We're going to see some of those results now. All right, so we have anti-police violence advocates. We have a large number of birth workers in this space. We have community-based organizations. We got community members. We have researchers, healthcare providers, policymakers, and we have other folks in this space. We have most of you guys are joining us from the Bay Area. We have some folks from Fresno, from Northern California, other parts of Northern California, Southern California, the Midwest, the US Northeast, the South of the US, and the US West, not in California. So thank you so much for joining. That's really great. All right, so for this month, we always have our organizational highlights, and for this month, we are highlighting Cameo House. The Center on Juvenile and Criminal Justice Cameo House is a long-term transitional and alternative sentencing program for homeless and formerly incarcerated women and children in San Francisco. The program provides on-site case management, a safe and stable living, and an array of services. A January 2021 external program evaluation found that 22 women and 18 children served from September 2019 to September 2020, 100% of those participants with substance issues showed a decreased use at Cameo House. 89% of participants achieved one or more of their program goals. 85% of the participants report that they feel safe at Cameo House. 77% of the participants gained and sustained employment. 72% of participants returned to education, whether that be their GED, their high school credits, or City College of San Francisco. And 78% of the graduating participants moved into permanent and stable housing. This is an amazing program. If you want to learn more, you can go to bit.ly, Cameo House Info. And if you'd like to contribute to their mission, you can do so at bit.ly donate Cameo. All the information is in the chat. So now we're going to introduce our agenda and our presenters for tonight. First, we're going to hear from Dr. Dana Goyne on her recently published paper on police violence. She will also share some general findings from other papers published on this subject. I'll be introducing her full bio in just a minute. Next, we'll host a panel discussion with community members who are making a difference to fight against the impacts of police violence. I'll briefly introduce our panelists today, and you can read their full bio at the link in the chat. So first, we have Katrina Serrado, who is a family physician who is nearing completion of an addiction medicine fellowship in the Department of HIV, ID, and Global Medicine. She has also been a member of DPHMustDivest, advocating for increased safety for patients and staff at SF General Hospital through the removal of law enforcement and investment in trauma-informed, accountable, and effective alternatives. Tiana McMillan is a PTBI Community Advisory Board member and a proud native of Fresno. In addition to working full-time in identity theft, she is a mom of a 1-year-old and a passionate advocate for mental health, mothers and children, and Black families. She has recently been certified as an RI, International Peer Support Specialist in maternal mental health. We also have with us Amy Murtha, who is a specialist in maternal fetal medicine, which focuses on managing the health concerns of high-risk mothers and fetuses before, during, and for a short period after pregnancy. Her research has focused on understanding the causes and management of preterm birth. She chairs the UCSF Department of Obstetrics, Gynecology, and Reproductive Sciences. After the panel, we'll have some time for your questions, so please utilize the Q&A function on Zoom throughout this event if you would like to ask questions. So before we begin, we want to recognize a couple leaders who are not able to join us as speakers today, but who have made a huge impact in protecting communities of color from police violence through research and action. These include Asmara Jabari, Ana Delgado, Brittany Chambers, and Andrea Jackson. Of course, there are many more, but we wanted to specifically call out and say thank you to these leaders. With that being said, let's dive into the program. And to start us off, I want to introduce Dr. Dana Goin. Dana is a postdoctoral scholar for the UCSF's Program on Reproductive Health and the Environment. She received a PhD in epidemiology and a master's in biostatistics from the University of California, Berkeley. Her research focuses on the social and environmental factors that shape population-level differences in maternal and perinatal health, and the biologic and behavioral mechanisms that explain those disparities. Let's give her a warm virtual welcome.
Thank you so much, Chanel, and hi everyone. Thanks so much for having me today. I'm extremely honored to have been asked to present here, and I'm very much looking forward to hearing the panel discussion. So as Chanel mentioned, today I'm going to be talking about a paper that I led, which was recently published in Pediatric and Perinatal Epidemiology about the occurrence of fatal police violence in California communities and the hazard of preterm delivery. So next slide. Before we get started, I would like to take a moment to acknowledge my co-authors, without whom this project would not have been possible. And I'd also like to acknowledge the funders that supported the project. Next slide. And so, as we all know, in communities of color, residents are exposed to greater police surveillance and greater use of force. And this is independent of situational factors like resisting arrest, officer characteristics like training, and contextual factors like the neighborhood crime rate. And in particular, Black residents are more likely to be victims of fatal police violence compared to people of other races or ethnicities. And these patterns can be linked to both discrimination and residential segregation, which continues to facilitate racial inequity and exposure to police violence and its consequences. So police violence is a critical problem in public health. And given that police violence disproportionately occurs in communities of color, affects people of color, and is rooted in the institutional authority of the state, it's a form of structural racism that contributes to health inequities. And here, health inequity is defined as the fair opportunity for all people to live healthful lives. And this means that no one is restricted from achieving their full health potential by poverty or discrimination or other social or economic forms of marginalization. And next slide. So while we know that there are health inequities that arise from physical victimization by police, witnessing or hearing about police violence also has detrimental health effects that result in inequities. So for instance, here are several studies that show that exposure to police violence, either by witnessing or hearing about it, can lead to adverse mental health outcomes, including psychological distress, psychotic experiences, depression, PTSD, anxiety, and suicidal ideation attempts. And I'm excited to hear more about this in the next Collaboratory in August. Next slide. There's also a robust scientific literature documenting a link between poor mental health and or stress during pregnancy and an increased risk of preterm delivery. So for instance, maternal experiences of depression, anxiety, psychosis, and bipolar disorder have all been linked to increased risk of preterm birth, which is defined as delivery before 37 weeks gestation. And similarly, experiences of stressful life events during pregnancy, including the death of a family member, job loss or other financial hardship, and incarceration of a family member have also been linked to increased risk of preterm birth. Next slide. So there have been several calls for more research on the topic of police violence and pregnancy outcomes, but only 3 studies, including our recently published study, have examined this question, and all 3 of these studies were published this year. So one other recent study found an increased risk of low birth weight among people who lived in counties with 2 or more police-related deaths in the year before they gave birth, but this effect was only seen in higher income counties. And another study found that for each additional police-related death in a metropolitan area in the first 6 months of pregnancy, there was a decrease in the total number of live births. And this really suggests potential pregnancy loss due to miscarriage. And the study observed stronger effects among Black compared to white women. So given the lack of research on this topic, we set out to study the relationship between living in a neighborhood in California in which someone was killed by the police and the hazard, which is kind of similar to the risk of preterm delivery. And given the differential burden of structural racism on Black mothers or birthing parents, we also wanted to evaluate whether the associations differed by race, ethnicity, and if the victim's race was the same as the mother or birth parent's race. Furthermore, given that fetal sex hormones can interact with the physiologic stress response and the immune system to jointly affect risk of adverse outcomes, we also hypothesized that the associations might differ by fetal sex. So for this study, we used data from the California birth records from 2007 to 2015, the California death records from 2006 to 2015, and the fatal encounters database. So the California death records used the cause of death codes to identify deaths due to what is called legal intervention. And these records capture where the victim lived at the time of their death. However, there's some prior literature that suggests that these records likely undercount deaths due to legal intervention. And so for this reason, we also included the fatal encounters database of incidents of fatal police violence. And this database is publicly available and is compiled by paid researchers and crowdsourced contributions using media coverage and public records to identify instances of police action that result in a fatality. And every entry is validated against other existing media databases and data from government agencies. And this data captures where the incident that resulted in a fatality occurred. So we linked pregnancies with incidents of fatal police violence by matching the census tracts of pregnant people to incidents of fatal police violence and mapping the dates of pregnancy to the timing of the death. So for example, we would use a birth date and the gestational age of delivery to estimate the date of conception. And this gives us a pregnancy window for each person. And so this is represented here on the slide by the black arrow. This represents a pregnancy window. And then we compared the dates of police killings to all pregnancy windows within each census tract. And so any person was classified as exposed if a police killing occurred in their census tract while they were pregnant and considered unexposed otherwise. And so we limited our analyses to census tracts in which there was at least one police killing during the study period and compared women who lived in the same census tracts but were pregnant at different times and therefore had different exposures to police violence during their pregnancies. And so we estimated the hazard, which as I said before is similar to the risk of preterm delivery among women who were exposed and unexposed to incidents of fatal police violence during pregnancy who lived in the same census tract. And Because they are thought to have different causes and potentially different implications for infant health, we split our analyses into 4 different subtypes of preterm birth. So we looked at extremely preterm, which is from 20 to 27 weeks, delivery between 20 to 27 weeks, early preterm, which we defined as delivery between 28 to 31 weeks, moderately preterm, which is delivery between 32 and 33 weeks, and late preterm, which is delivery between 34 and 36 weeks. And we examined overall associations, and then we stratified by fetal sex and maternal race ethnicity. And these models controlled for age, educational attainment, health insurance type, race ethnicity, parity, year of conception, and the season of conception. And we also estimated race concordant analyses. So that is whether the incidence of fatal police violence involved a victim of the mother's own racial or ethnic group. And so for these analyses, we matched the race ethnicity of the victim on the death records or the fatal encounters database to that of the mother on the birth records. So here are the first results. And so this plot on the y-axis shows the hazard ratios, and then along the x-axis are the subtypes of preterm birth for extremely early, moderate, and late preterm birth by exposure to fatal police violence. And the results for using the death records are represented by the green circle, and the results from the fatal encounters database are represented by the blue square. And so overall, you can see we observed a small increased hazard of late preterm delivery between 34 and 36 weeks gestation that was associated with exposure to fatal police violence during pregnancy using both sources of data. So we found a hazard ratio of 1.05 using the death records and 1.03 using the fatal encounters database. And so this corresponds to approximately a 5% and a 3% relative increase in the hazard of late preterm birth among those who are exposed to fatal police violence compared to those who weren't. And so next we looked at the associations separately by fetal sex, and we found stronger associations among the female compared to the male fetuses. And next slide. Yeah, so here we're highlighting the results are stronger for the female fetuses. The hazard ratios for the female fetuses were 1.07 and 1.06 for the death records and the fatal encounters, respectively. And again, so this corresponds to approximately 7% and 6% relative increase in the hazard of late preterm birth. So these next plots are the findings when we matched the race of the victim and the mother or birthing parent. So for example, these show the hazard ratios of preterm birth for Black women when a Black person was killed in their neighborhood during pregnancy, and the same for white and Latinx people. And you can see that we observed stronger associations for moderate preterm birth with fatal police violence for Black mothers in this scenario when the victim was also Black. In the death records, there was an 81% increased hazard of delivery between 32 to 33 weeks for those who were exposed to fatal police violence against a Black person during pregnancy. And in the fatal encounters data, we observed a 35% increased hazard. So then next, we also stratified again by fetal sex, and again observed stronger associations among the female fetuses. And this was particularly true for delivering between 32 and 33 weeks for Black mothers. So in the death records, the hazard ratio was 2.06. So this indicates that Black mothers carrying female fetuses who were exposed to fatal police violence against a Black person during pregnancy had more than double the hazard of delivering between 32 to 33 weeks compared to the Black mothers who were unexposed. And for fatal encounters, the hazard ratio was 1.75, indicating a 75% increase in the hazard. So there were some limitations of our study that I would like to acknowledge. In particular, we used administrative data that has several important sources of measurement error. So first, we only had access to where women were living at the time of delivery. So any women who moved during pregnancy could have potentially had their exposure misclassified. In addition, the data on fatal police violence has not been reliably collected in California or in the United States more broadly. So we attempted to try to address this by using two different sources of data that capture different measures of fatal police violence. but more robust data sources would be really helpful in doing this research. Additionally, in line with kind of existing research on neighborhood violence and health, we use census tracts to characterize maternal exposure. However, as a geographic unit defined by the government, we know that they are an imperfect proxy for communities, and our approach might have resulted in some exposure misclassification if people were exposed to deaths in nearby tracts. And finally, our study population only included singleton live births, although we did include stillbirths in a sensitivity analysis. However, these data do exclude any spontaneous or induced abortions, and we know that stressful community events have been shown previously to increase male fetal loss, and community violence exposure could potentially shape decision-making around pregnancy intendedness or continuation. And so this could have introduced what's called live birth bias into the analysis, although we expect this bias to be towards the null, which would make our estimates conservative. And finally, the focus on acute exposure really helped ensure that the people we were comparing were as similar in all ways other than their exposure to fatal police violence as possible. But we do know how residential segregation and neighborhood stratification can affect both a person's exposure to fatal police violence and their risk of adverse health outcomes. And so our focus on acute incidents likely only captures a small portion of the relationship between police and community interactions and maternal and infant health. And so we're really looking forward to seeing more research that finds innovative ways to study long-term exposure to police violence, as it could be more relevant for understanding inequities in reproductive health. So in conclusion, our results suggest that exposure to fatal police violence during pregnancy is associated with an increased hazard of late preterm birth. And we also observed stronger associations for Black mothers and birthing people when a Black person was killed in their neighborhood. And this suggests that reducing police violence could help mitigate inequities in preterm birth. So I want to highlight that in 2018, the American Public Health Association released a policy statement regarding law enforcement violence as a public health issue, with suggested steps for reducing fatal police violence. And this policy statement builds on work from community organizers, but was written by public health researchers. And what it really indicates is what's needed most is a shift in how government resources are allocated, and suggests moving those resources away from criminalizing and policing marginalized communities to investing in their health, safety, and well-being through housing, food security, and quality health and education systems. And I'm looking forward to hearing more about this in the panel discussion in a few minutes. But overall, kind of the takeaway is that reducing police violence really does hold promise to reduce racial inequities in preterm birth in California. So thanks so much. I'm really looking forward to hearing from the rest of the speakers, and thank you for the invitation to present. Before we move to the Q&A period, I'd like to take just a quick moment to shout out another study done by a UCSF researcher who couldn't be here today, Megan Harada, who conducted a study to examine how physicians understand the role of law enforcement in the emergency department, and to identify how the presence of law enforcement officers might impact the delivery of emergency medical care. And so she and her co-authors conducted interviews with 20 emergency physicians in Northern California, and found that most participants reported interacting frequently with law enforcement and had mixed experiences. So sometimes they found officers to be helpful and collegial, while other times they found police presence to lead to interruptions in important treatment, breaches in health privacy, and diminished patient trust. And another clear highlight of her study was that the lack of clear definition of the role of law enforcement officers in the emergency department can lead to contentious interactions with emergency room physicians. And so I've added the citation to her paper, which is in press here for anyone who's interested. So thanks so much.
Thank you so much, Dana, for that great presentation. We have a number of questions for you, and I'm going to start with this question. Since 20 to 22 weeks gestational age is considered peri-viable, non-viable, what was the rationale for including these in your data collection?
Yes, we debated whether or not to include anything to basically limit our definition of extremely preterm from 20 or 22 weeks, but because one of our sensitivity analyses included stillbirths and fetal deaths after 20 weeks, we wanted to make that consistent between the analyses. So there are extremely few births between 20 to 22 weeks, and they are, but for the sake of comparison with the fetal deaths, that's why we included them.
Great, thank you. I'll go to the next question. Someone said they may have missed this earlier in your presentation, but how do you define police violence and how is it measured?
Thanks for the question. So the definition of police violence differed a little bit just because of the two different data sources we used to define it. So the first we used was the death records. And so basically anyone whose cause of death was listed as legal intervention was classified as a case of fatal police violence. And then for the fatal encounters database, basically it only includes any person who has an involvement with the police that leads to a fatality. And so those were the two definitions that we used.
Great, thank you. And another question is, why do you hypothesize there's a difference between male and female fetuses?
So we based this hypothesis based on some evidence that stressful events, and in particular kind of community stressful events, can increase fetal loss, but predominantly among male fetuses. And this is kind of looked at as people often look at the sex ratio, so the ratio of male to female fetuses that are born in a given time, and then map that to when people were pregnant and when this community stressor occurred. And there are several studies that find the ratio of male fetuses declines after stressful events. And so that was kind of one of the motivating factors for why we decided to look specifically to stratify between male and female fetuses.
So another question sort of related is, why is the risk greater for female fetuses?
So our hypothesis, and it's kind of working hypothesis because we hope to kind of follow this up with some more research to confirm it, is potentially that there are male fetuses that are being miscarried potentially as a result of exposure to fatal police violence. And so you see a stronger association among the female fetuses because they are surviving to be born, but are born preterm, whereas the male fetuses are not, are being miscarried. So this is a working hypothesis that we have that I hope we'll be able to evaluate at some point.
Great, and a final question is, can you just tell us what your next steps are for this work?
Yeah, so studying the association of police violence with spontaneous abortion and miscarriage is something I'm very interested in, and is hopefully something I'll be able to study soon.
Great, thank you. So before we get into our panel, I just want to let everyone know that Tiana, our community member, had a family emergency and unfortunately won't be able to join us tonight. But we are now going to transition into our panel discussion. All right. All right, and thank you so much again, Dana, for that amazing presentation. And for the attendees who have additional follow-up or clarifying questions, we encourage you to continue to type those into the Q&A box, and we'll be able to type and answer your question at the end of the program. Moving on to the panel, I would love to hear everyone's reflections, first and foremost from the reports. So what is one reflection or takeaway that you want to share from the research that was presented? And I'll start with Amy.
So thank you so much, Chanel. I was actually taking notes furiously and was the one who asked the question about what the next steps are, because I really anxious and excited to have more data to help inform policy. And I, from my position, which is clearly a position of power and privilege, I oftentimes lean on the science to help move work forward. And so hearing Dana's work feels upsetting, and also at the same time like an opportunity to really move the conversation forward in a more meaningful way.
Wonderful. Katrina, what's your takeaways or reflections?
Thanks, Chanel. I had so much was going on. I feel like the presentation could really supports a lot of the work that DPHMustDivest is working on currently. I think the piece about that the data on police violence is not reliably collected is parallels that it's similar that in our hospital where the sheriffs are the cornerstone of our security process, that use of force incidents are not transparently collected and the data is not necessarily available. Sometimes we're resorting to a similar version of documenting police violence by patients and other caregivers having videos of sheriffs using force against patients. So that was one of my reflections. We know that part of why our organization started was that in the year of 2019-2020, there were 111 use of force incidents at the emergency room at General Hospital, and 70% were Black patients, in spite of the fact that Black patients only represent 24% of the emergency room visits. So this exposure to like police violence is huge. And the other thing I was thinking about was just overall this knowledge that we have about stress during pregnancy and the increased risk of preterm birth. I'm a prenatal provider for Team Lily at San Francisco General Hospital, and we take care of people who have substance use issues, have homelessness or severe mental illness. And the policing violence that was discussed by Dina is one type of violence, and the other type of stressful violence that our patients experience is this surveillance, or the feeling that the police state or child welfare organizations might remove their children from their care at delivery. So it's kind of like holding this surveillance state and the potential for violence causing stress on my pregnant patients throughout the entirety of their pregnancy. So those are just a few of my reactions.
Thank you so much, Katrina. I'm going to actually come right back to you. And just thinking about the Bay Area, I would just love to hear from you. You founded the organization called DPHMustDivest that you're representing today. Can you share with us the story of how and why this coalition was formed in 2020?
Yeah, no, I did not found it. Actually, two of the leaders that you highlighted, Asmara Gabre and Ana Delgado, both midwives at the General, are part of the story of founding this organization. But basically, a family doctor named Maisha Davis wrote a petition in response to this evidence that I just talked about, this use of force and the racism at the General, to say we need to disarm our deputies at the hospital. We need to do de-escalation. We have a racist security system at the hospital, and we need to take immediate action to reconcile this. We need oversight, we need accountability, we need transparency. And actually her petition included that the Department of Health should not utilize the Sheriff's Department for security, and instead we should have a community investment, a community response. We should hire individuals who are committed to trauma-informed care, healing. And there is a really great response to her petition. And so people who work in health and also in prison abolition in the city have come together, and we meet weekly. Shortly after that petition, there was a rally outside of the hospital, and then Asmara Gabre, who we'll hear from in just a minute on a video that she recorded, witnessed use of force by sheriffs and decided, how can I keep going to work in these conditions? Something dramatic needs to change. So if Selena, I think, had it ready to go, so we can hear from Asmara.
Yes, my name is Asmara Gabre, and I'm a midwife in San Francisco. I work at San Francisco General Hospital usually, and on July 8th, I was leading work and I noticed 6 sheriff deputies following a Black person and harassing the individual to leave the premise. The person repeatedly kept asking for their EBT card and their phone charger, and obviously was displaying signs of mental health instability. And the officers continued to tell the person to leave very aggressively, also disclose their COVID positive status publicly, and were informing me that I needed to leave. Eventually were laughing at me and walked away from me and another person who both identify as Black, leaving us with a person that they required 6 officers to leave, and told me, it seems like you know it all. You should be able to handle this, and walked away. To this date, I don't know the name of the officers, but that day I wrote a public letter to our hospital administration in our city that I was on a sick strike because I'm sick of their racism and targeting of Black people. In the last year, there's been over 100 cases of force by the sheriffs, and 70% of them have been towards Black people. Our emergency department has on high ends a traffic volume of Black people that is 24%. So as you can note, that is a disproportionate amount of harm happening to our Black community. And additionally, through my years of experience at the General, I've witnessed other forms of harm from sheriffs, including headlocking Black individual who was asking to be released and saying they couldn't breathe, to creating a physical barrier from them entering a person's room who was in labor to on a false call from a nurse reporting harm or fear of safety, when many people, all people of color present, denied that occurring. So that's just kind of a really overall summary of just some of the pieces of my current status on demanding that the sheriffs be removed from the hospital setting. Less than 1% of hospitals in the nation use police as primary security, and why is it that our only sanctuary hospital in San Francisco utilizes such a force that causes harm? So thank you for inviting me to this space, and I look forward to the conversation.
Thanks, Selena. I'll just wrap up by saying that DPHMustDivest is invested in the safety and well-being of our staff and employees at the hospital, like Asmara, like nurses throughout the hospital and in the emergency room, as well as patients. And that's part of what motivates us to keep working on all of this. And so I think that I answered, hopefully I answered the question.
Yes, thank you, Katrina, and just thank you for your leadership and the leadership of others in this organization. I'm now going to go to Amy. Amy, you are not an official member of DPHMustDivest, but after learning about this issue, you decided to take your resources and time as the chair of UCSF OBGYN department to be involved in conversations regarding the presence of sheriffs at SF General. What was your experience in these conversations, and why did you feel it was important to dedicate your time to this?
Yeah, so thank you, Chanel. I think maybe I should start by saying that I'm Asmara's chair. I suppose that's where my story starts in this work. And I should also just say that, you know, I've only been at UCSF for 3 years, 3 months and 21 days. Not counting, but that somebody pointed that out to me today. And I came from an institution that was in much more of a suburban setting, and many of the experiences here in San Francisco are actually very different than the experiences in that more sort of suburban / rural environment, knowing full well that the racist behavior exists in all of the healthcare structures that I've worked in. But the experiences here in San Francisco, I think, have been certainly more intense and more, in some ways, an opportunity to move the work forward in a more meaningful way. And so I am a white woman with power and privilege. There's just no other way to say that. It is true. And so I come to these conversations trying to understand what is the best path for me to have influence, what is the best path for me as an individual to be impactful. And I can choose to join DPHMustDivest. I can choose to work behind the scenes in a way that helps to push the conversations forward in a meaningful way, in support of my faculty and the patients that we care for at ZSFG. And so for me, I think in the position that I'm in, I view it a little bit like you have to be part of the system to change the system, or you're not part of the system and you can try and change it from the outside as well. And we need people on both the inside and the outside to really dismantle the structures that disadvantage certain populations, especially in this context. My role is from inside the system, and my opportunity in these conversations was to actually hold leadership accountable, advance the work, make sure that Asmara was being seen and heard in a way that felt respectful, because that was really important for me, and to navigate a path that would allow her to continue to have the incredible impact that she has, both for the care for her patients and also in the midwife community as well. That answer your question, Sunil?
Thank you so much, Amy. So Katrina, I would like to hear from you as well on your why. You're a family physician with obstetrics training who recently joined an addiction medicine fellowship at UCSF. Why are you so passionate about abolition, especially as opposed to reform? What might you say to people who are concerned that without officers present, they may not be safe?
I think I also, like Amy, I'm a white woman too, and I think about my consciousness of understanding racism and police violence in a few ways. But I remember as a child, my mom telling me that she grew up in a household where there was domestic violence, and actually my grandfather was a New York City police officer, and so the police to her was never somebody safe that could be called, because there was cronyism, there was just not a feeling of safety, and that was for, I guess, what I understood then to be a personal reason about calling the police, that the people that would come would be his friends or who knows. But now I understand it, as time has gone on, I've understood more in more depth how the police can be violent and harmful when they do show up, whether it's a mental health crisis, whether it's racism, whether, videos that we've seen where police have killed innocent people. I remember being in college, and one of the first times I heard about, I just remember being kind of like, well, really, did that police officer really shoot and kill an unprovoked? Like, there must have been some other explanation for it, right? Like, you're trying to wrap your head around some horrible thing that happened, but really, like, the data, it bears out that our policing is a product of white supremacy and racism in our culture. We know that police started as patrols to make sure Black people did not escape from slavery, and the institutions that we have now are continue that racist agenda and white supremacist agenda. and also misogynist agenda. And so I'm really inspired by abolitionists, just like people back in the 1800s where slavery was a normal thing, and they were imagining a future to say, this is not right, we need to have a different kind of society. Abolitionists now are saying, wow, the mass incarceration has grown out of, the 13th Amendment, and we're incarcerating people to get free labor and also to remove the humanity of Black Americans, also people who use drugs, and criminalizing normal behavior to justify, locking people up, putting them in cages is something that I can't now that I feel like I've seen the light. And I think there are, I just want to point out this book. Maybe this is my background is a little fuzzy, but it says "We Do This Till We Free Us," and it's a book of essays by Mariam Kaba. And there's just a question that she asks in one of these essays that I think is really revealing of like what brings me to abolition. She says, "What happens when you define policing as actually an entire system of harassment, violence, and surveillance that keeps oppressive gender and racial hierarchies in place?" And I think coming at it from that perspective and thinking, we need to have a healing community here in the hospital. We need, we need to have systems where harm can be repaired and where we can ensure our safety and well-being that does not involve locking people up, and having the law enforcement in our hospital to like be a pipeline from the hospital to prisons and jails is just not right. Just like, a lot of people who advocate for the abolition of the child welfare system as we know it also say that foster care is a way of removing children, especially Black children, from their families, from their communities, and that in its own way, it's a pipeline to prison. And I do some care at San Quentin, and when I talk to people, who are there, sometimes it's just like, wow, we really could have as a society thought about a better way to handle the drug use that started when you were an 11-year-old. Like, we are spending a lot of money though, because these systems already exist and they're getting more and more powerful, and more moneyed. We are spending so much money on that to imagine something really different and investing in something that really works for us, and helps us undo white supremacy and racism in our society. It's very inspiring to me, and we need to invest that money, that time, that energy, into the society that we want to have, which is a society free from the prison industrial complex.
Wow, thank you for that powerful history, Katrina. And I'm gonna actually go back to Amy. In your role as chair of OBGYN and your long career of caring for women with high-risk pregnancies, you've had your own personal experiences and led many other providers who care for pregnant people. How have you observed the presence of officers and policing at hospitals and clinics? How did that affect yourself and other providers?
Yeah, I think so. Thanks for that question, Chanel. And so I come to my position as a high-risk obstetrician. I trained as an OBGYN, did fellowship training in maternal fetal medicine, and have been caring for pregnant women my entire career. And from the very early days, it was really clear and continues to be clear that having women feel safe and trust in the healthcare system is a really critical, important part of the care, and having access to appropriate care. And that in pregnancy, there are additional vulnerabilities that pregnant women experience, mostly related to the vulnerability of having their child taken away. And CPS referrals, whether or not we do urine tox screens, those types of things add another layer of complexity for pregnant women as they seek care and makes it that much more important that we try to create a space that feels safe, that they can trust. And that's not the case, especially in an environment where there's a policing, and it makes it incredibly difficult for women to feel safe even just walking in the front door in that environment. So for me, actually, in my entire career, even before I arrived at UCSF, this has been a focus and an intentional approach to work to try to create an environment where women feel safe entering care. And I think actually, again, since my arrival in San Francisco, I think have come to appreciate what it means to provide care in a city, in an environment that I had not understood actually before coming to UCSF. That San Francisco General in particular has sheriffs as their security services. And I'll admit, actually, my first time walking up to labor and delivery at CSFG was wondering why there was a uniformed officer sitting outside the birth center. It felt very odd to me, like, and that's me actually, who wasn't frightened, but I can't imagine how that would feel to an individual who is a lot more vulnerable than I am actually walking into that place. So just as an obstetrician, I know that the impact of the structures that we have in healthcare make some spaces safer and not safe for certain individuals. And I just think it's such an incredibly important thing for us to create safe space so that women can get the care that they need.
Thank you so much for that powerful story. To wrap up this section, I'm going to ask the both of you, Katrina and Amy, how do you think people can advocate for community safety? What do you think our decision makers should hear and consider when creating policies about policing? And I'll go back to you, Katrina.
Thanks. You know, a lot of people ask about kind of the difference between abolition and reform. Excuse me. And, you know, people talk about body cameras, more trauma, anti-racism training for police officers, you know, other forms of essentially kind of reforming the policing institution that we know of. And, you know, I think that the concern is that we are further entrenching power in the police. And there's a long history in our country of spending more money on policing and prisons and jail than social services in our own communities, like, you know, even things like childcare, like, you know, imagining sort of to say that if we had a way of spending, reallocating funds and our imagination, instead of saying that the right thing to do is take this person away and lock them up, take away their right to vote, all of this, like, actually that system, while some people might say it's broken, prison abolitionists say it is getting the results that it was designed to get, which is further entrenching white supremacy, further disempowering and making safe and unhealthy, you know, minoritized groups. So I think about social movements and getting involved in really, there's so much learning that happens. DPHMustDivest has a weekly meeting on Wednesdays. It's all via Zoom. I've learned so much from Asmara, from Ana Delgado, from other like medical students, from people, disability activists in the community who come along, and just saying, like, you know, our tax dollars are going into doing something that we don't believe in. Even when I show up at work, you know, my employer is investing in this kind of system, which is not strengthening members of my community. And so we've had conversations with, you know, hospital leadership, like Dr. Murtha and other like leaders, to educate, to say like, wow, you know, we're white people here, some of us, and this is how we benefit from the system as it is, and how do we change it? And I really like this about Miriam Kaba's book, and just in general, that like don't go alone, right? Like we can't make changes by ourselves. We do things like don't travel alone in this space. It's like kind of dangerous, but like show up to meetings for organizations where people are trying to make things better. So
thank you, Katrina. I also want to highlight in the chat, shout out to Kendall and The New Jim Crow, really important book by Michelle Alexander. And just what we're really talking about here is the prison industrial complex. I don't know if folks are familiar with that terminology, but the money interests in, incarcerating Black and brown bodies, it's real. So I'm gonna now go to Amy on the question, how do you think people can advocate for community safety? What do you think our decision makers should hear and consider when making policies about policing?
Yeah, so I think, and again, I'm gonna probably speak from my lens, which is 30 years of academic medicine. And I can't help but come at it from what I feel like has been most effective in helping me move things forward, which is a data-driven approach. And so, so excited to hear Dana's research, and that's exactly why I wanted to know what our next steps were, because I'm really anxious for there to be additional data that it can inform conversations, and especially in the environment that I troll around in. Those data points actually are oftentimes the things that centers the conversation in an unemotional and objective way, and gets us past a little bit of the us versus them mentality, which can be problematic sometimes to really move things forward. So so I'm really looking forward to more data, and I hope that others join Dana in her work to really expand the volume of research that will help us to move policy and move structures. And then I think it's the responsibility of each of us at our institutions and to be able to actually examine the things that we do on a day-to-day basis and understand and appreciate exactly how those impact certain women or certain populations in an adverse way. I know that things like our policies around the things I talked about before, CPS referrals, urine tox screens, when do you call security for, when do you do room searches, those things, every institution has a policy. And I am certain, because I've seen it, that if you really examine and read the policy and the guidance for the on the ground staff on how to implement those policies, there are racially biased language in every one of them. So really stepping back and taking a deep dive in all of those policies to restructure them in a way that is more equitable and can be applied, and actually creating structures so that it makes it more and more difficult for people to apply those things in a racist way, racially biased way, which is what we see now. For example, creating huddles before a CPS referral is submitted, so that we all come together as a group, the care providers, the bedside nurses and the physicians, and decide whether or not this is really justified. That gives space to conversation, gives an opportunity for people to speak on behalf of the patient in a way that that will value their perspective and their lived experiences and how they come to healthcare in a way that actually will hopefully begin to reduce some of the impact of the racist structures that exist in our healthcare environments.
Thank you so
So
much.
that's what I'm going to do, Chanel.
Thank you so much, Amy and Katrina. As I'm listening to this conversation, I'm thinking about policy, and I'm also thinking about advocates on the ground. So I want to shout out to Ella Baker Center, the Young Women's Freedom Center, United Players, Legal Services for Prisoners with Children, the BIPOC Family Justice Summit Coalition, and then also a specific policy that's coming before the Assembly as we speak is ACA 3, the Involuntary Servitude, authored by Langer to stop unfair labor in prisons. We know we have all these fires around California. Who was putting out those fires? It was folks incarcerated. And so this bill is going to help create a pathway to a living wage for prisoners and really stop what folks consider to be slavery, the continuation of slavery in our state. And so I want to just first thank you for all your thoughtful responses. We'll be moving into Q&A from the audience. So all of you out there, just please type your, you can type your questions in the Q&A box, but you can also unmute yourself. And while we're waiting for questions, we want to update the audience that 2 months ago, in May of 2021, the San Francisco Department of Public Health announced that they are proposing to reduce the sheriff's presence at healthcare facilities and invest in community safety alternatives. You can learn more about the DPHMustDivest movement at their website, DPHMustDivest.com, which will also be posted in the chat. With that said, we do want to emphasize that all the viewpoints from our speakers are their own, and our goal is to simply educate and inform our communities on a topic that impacts birthing people and health. In order to prioritize hosting this event in a trauma-informed way, we decided to not involve any sheriff or law enforcement representatives. We hope the research and the panelists today have added valuable perspectives to everyone tuning in, and we are looking forward to getting to your questions. And again, shout out to Osmera. All right, so we will now go to our questions. And if you have a question, feel free to also unmute yourself. Let me see if I see raised hands. Oh, I'm raising my hand. So if you do have a question, feel free, you can raise your hand or just unmute yourself here.
I was just going to say one other thing, which was a reaction to Dina's presentation, which is that, as a doctor getting educated in our current medical system, we learn a lot about race as a risk factor for bad health outcomes, for instance, or more dangerous health outcomes like preterm labor. And I think that seeing this research and having more understanding, thanks to researchers, about how what is it, for a long time there was a racist idea that it had to do with a biological function. It wasn't about racism, which we now know it is racism. And then the question is like, how is racism experienced, and what are the ways that racism impacts people's bodies? And exposure to police violence being a marker for racism. And I just wanted to put that out there, as this is like a really important area, and thinking about police in general, over policing in Black communities is like really something that's like impossible impossible to overcome, and therefore like the work of abolishing the police and thinking about different ways of creating safety and security in our society that's more equitable goes hand in hand with Dina's research.
Thank you. I actually have a question here. It says, thank you, Katrina, and thank you for bringing on Marianne Kaba's book. I'm an abolition activist myself and agree completely. I'm shocked that the hospital uses actual sheriffs. I'm in San Diego, and I'm interested now to see if we can do the same at any hospitals here. Has the hospital responded at all to the movement around divesting?
Yeah, thanks for the question. There is, like Chanel just mentioned, DPHMustDivest members have been meeting with hospital security, and actually I think we're able to influence the plans that the security was proposing in terms of decreasing the sheriff's force. And the truth is that like there's a big social change that needs to happen around what is security. Now that the sheriffs sort of had their foot in the door, it was over the last 10 or 15 years that they replaced a private security company that also did not have accountability to the community previous to their coming into the general hospital. But there's a sense that maybe the sheriffs do keep people safe. And I think this is part of a question I didn't answer before, Chanel, which is, what do we say to people who think the sheriffs do make us safe? And part of what I say is what I've heard people say in the emergency room. You know, sometimes the patients can have mental health crises, they can have violence, human beings can do harm to other people. And so how do you prevent that harm? If somebody does like pull a weapon out, right? Do you need somebody there who can arrest them, or do you need somebody there who can de-escalate, right? Or do we think of ways that we can have an environment where people don't get escalated to begin with? And currently there are often assaults on staff at our hospital, and the sheriffs being there has not prevented that. So we think that, and we know that if there are more staff people, including nursing staff, there's a behavioral emergency response team that the security plan, the DPH security plan has taken up to expand that. That was one of the demands of Dr. Maisha Davis in the original petition that started DPHMustDivest. So I think they are hearing this collective of leaders and thinkers, and so doing more of this education and just calling for accountability, like Asmara has been doing, as part of it. Works. And Miriam Cabo, you know, what people said works. They may feel like so grand what we're trying to achieve, but it happens if we fight for it.
Yeah, I want to give Dana and Amy an opportunity to respond to this as well. Anything you're hearing about how hospitals are implementing this change?
But I think, yes, I do think that many hospitals, including those in our very own city, are creating de-escalation teams or creating a different mechanism to support the patient's perspective. And those are being crafted in a really careful way and being piloted so that they can be rolled out in a way that hopefully will be effective. I still remain a little concerned and feel like there's a tremendous amount of work and more deeper learning and understanding that needs to be done before we can feel confident that those systems are going to actually help. But the idea of being able to call a different number if you just need help settling things down and not really security, that there's not really a safety risk. And so I think that's one really important initiative that's happening at many institutions, both locally and nationally as well.
Did you want to respond, Dana? Anything you're hearing from your research?
No, I'm not sure I have anything to add to that question. Thank you.
Thank you. All right, I'm seeing if there is additional questions or hands raised. If not, I would like to give everyone the opportunity to just give your final thoughts on this issue. There's been a lot shared. This has been a very powerful conversation, and I know we have a long way to go in changing the system, and just want to allow for all of you for any final thoughts, any reflections and next steps. And any encouragement you have for folks in the audience. As we heard before, there's folks from all over the country who are tuning in here that want to figure out how to do this work as well. In San Francisco, as usual, we're sort of leading in this space in a way, and folks want to hear advice. So, oh, we have a hand from Letitia. You can unmute yourself.
Hey, good evening, everyone. So I am in my first year of the PhD program at UNC. I'm doing my PhD in nursing. I'm a Hillman Scholar in Nursing Innovation. So I'm at the beginning stages of defining my research question. And right now, broadly, my interests are police violence and women's health risk, particularly looking at cardiometabolic health risk in young African-American women. And as I'm looking in the literature, it's kind of difficult to define police violence and reliable measures of like obtaining data on that. So I was just wondering if you guys had any recommendations of good databases or validated tools, or just how you really were able to define it for your research.
Yeah, that is really exciting, and I'm excited to hopefully read your research at some point. Yeah, so I agree that the quality of data is a challenge. I think there are, in addition to sort of just using death records, also we know that non-fatal police violence is also a huge problem. And so there have been some studies that have used hospitalization, emergency department records to, and identified injuries that are due to legal intervention by using the ICD-9 or the ICD-10 codes that are specifically for that. So that is one way to sort of identify those cases. And then there are several sort of journalistic enterprises, in addition to the Fatal Encounters database that I talked about earlier, that are trying to collect these incidents. And I believe there is one by The Guardian, I believe it's called The Counted, and Mapping Police Violence Projects. So there are a couple different initiatives to try to get better data collection around this. And I think in the slides, I have linked some citations to papers that have compared different data sources for identifying police violence. And so I believe the slides will be available. So that might be a good resource as well.
Awesome. Thank you so much. That was definitely a challenge. I wanted to look at fatal and non-fatal police violence and police interactions. And I was just like, wait, where do I find, because I went and I submitted an interdisciplinary grant this summer, and it was funded. So I took a course at Columbia looking at the epidemiology of police violence. And then I'm also taking some qualitative courses at UNC to kind of look at how to do qualitative work within historically oppressed populations and make sure that you're really doing culturally attuned work. And that's something that was echoed even in the presentation at Columbia, just, how difficult it was to, get the data and just define it. But I thought your work today was very interesting, and I definitely enjoyed learning more about it. So thank you for the opportunity.
Well, thank you for all your work as well. We do have a number of questions that are actually coming in. I'm going to go to this question. I'm wondering if you have seen or worked with doulas in a way that has impacted patient interactions with police. If so, what did that look like? So for Amy and for Katrina, I believe that would be a question for either of you. How do doulas support with the patient interactions with police?
So I unmuted before Katrina did, so I guess I'll go first, and I'll start by saying that I think the way that doulas, the role of the doula in the healthcare environment is really to be that support person for the patient, and to prioritize the patient's wishes in the healthcare decision making, and actually in how they're interacting with the treatment team. So. And I will say that the past year and a half, we've had not as much doula presence on the units because of COVID. I think for that reason, it makes it a little bit more challenging to answer the question because of COVID, we had a really long period of time where we had no doulas on the unit at all. And I think that was true of the SFG, although I'm not 100% sure if that's true. I think we had no doulas on the UCSF side for a much longer time than the SFG side did. But the the doula is certainly the advocate for the patient and can actually serve in that de-escalation space when things actually do become problematic. And I don't know, Katrina, if you want to add anything to that.
I agree. I'm thinking about Asmara's comment about, a nurse potentially considering that something was harmful and calling the police. There was a question from somebody in the Q&A also about how do we prevent, how do we retrain ourselves? How do we retrain staff in the hospital to not call immediately? In fact, there are two very disturbing episodes of use of force or just kind of sheriffs responding to security concerns that involved a 5-year-old and a 7-year-old, both Black children at San Francisco General Hospital. So, you know, and somebody else asked in the chat something about, you know, what do you do when someone's breaking into your house if you can't call the police, right? Oh my gosh, sorry. I don't know if you
I
guys
can
are
read
hearing
that question. Yeah.
Well, I guess just to say though, like, what do doulas do? They are people who are present when things are going down in an unfamiliar environment for people. You know, birthing people come into hospitals and maybe it's something they've never done before. There may be, we have a history of inappropriate treatment for people, birthing people, and people across all the hospital, like different realms of the hospital. And actually DPHMustDivest really likes the idea of healthcare doulas in general, not just doulas for birthing people. And I really don't know about the data related to that. I do know that having somebody to advocate for you, keep you safe, also be a witness to things that may seem kind of outlandish, like, whoa, you said that happened? That's a little bit, I don't know if I believe that, right? Just like my own incredulity when I first heard about like unprovoked police violence. And so, yeah, I don't know about the data, but I think more people, and that's an example of like investing in prevention, I think, or investing in something that is not policing, supports that are not about surveillance necessarily, but about helping people navigate. And, you know, I think abolition in general, part of what I like about it is that it's very creative. It's not necessarily like we have all the answers. And so asking more about what are the effects of doulas for people is a great question.
So we got some great questions coming in here. So Naisha is next. We're gonna elevate her to the panelists. Welcome.
Hi, can you hear me? Someone asked the question, it was about doulas, but I also have another question, which I think Kendallin kind of commented in the Q&A about it. How much is qualitative research being added to this conversation? Because I think especially, you know, white folks in research tend to lean more on quantitative data, but it's, as a Black person, a lot of the experience that I've had in this country are not quantitative. They cannot be measured. They are something that I experience every day. So how much is like just walking into a hospital and seeing a police officer and just having that fear is able to be measured? Because even if we don't die from that encounter, I have been fearful of the police since I was like 2, because I lived with domestic violence and they treated my family like crap. So like, how much of that is going to be put into the research as well? Because that's just as important in addition to quantitative. And I find that every time I'm trying to search for information or ways to train some of my colleagues on this, we're always looking for quantitative data. Well, what does the data say? Well, that data doesn't always look like numbers. So I'm just wondering how much of that is going to be put into research, and how long are we going to continue to wait and waste money on quantitative research versus listening to the people in the community that are telling you what's happening, right? How much more are we going to have to do this for like 30 plus years? You know, money can be funded to actually do the work that we're talking about, right? So I'm just wondering how much qualitative information is being included.
Great question. Who wants to? I see Amy, you unmuted yourself.
So Dana, if you want to go, I can start. Naisha, I really am grateful for that question, and 100% agree that quantitative research is not going to get us to where we need to be. And I don't know if you know of the work of Karen Scott, who is doing the Sacred Birth Study. It's a patient-reported experience measures of obstetric racism. So she basically has a Black-led, Black women-informed tool to be able to measure obstetric racism, and that actually is work that we've participated in at the UCSF side. Karen has given us right. Thank you for the link, Selena. Our feedback, we're working on some of the things that have been identified by Karen's work and are continuing to move that forward. But Karen's work is just so critically important, and is exactly the qualitative type of research that you're speaking of. Dana, did you want to add to that?
I just wanted to acknowledge that absolutely we need both, I think, quantitative and qualitative research. And I think qualitative research really does capture, as Naisha was saying, aspects that the data just can't reflect. And I think that is something I was trying to allude to in my limitations about using administrative data is limited and using and quantitative data can't capture kind of the texture of experiences that people are having. And I agree that both types of research are equally important and should be equally kind of highlighted when policymaking happens around this issue.
Thank you so much, Naisha.
Can I add one more thing? I just want to say out loud, Naisha, that you pointed out or said something that I think is really powerful, and I just I want to highlight it. What I think I heard you say, and maybe I have this wrong, is how long are we going to wait?
Yes, I think a lot of times we wait to make policy until the data is out there, and if the data is out there, Black people have been telling you, like all of us, for 30 plus years what's going on. So yeah.
Yep. No, you're right, and I just wanted to call that out as a point that's really important for us not to wait. That there's not an opportunity for us to wait another second, and the work has to be prioritized now. At the same time that while researchers like Karen and Dana can provide data along the way. So that's just really important. Those are not mutually exclusive. They should be happening in parallel with prioritizing both. Thanks.
Thank you. We have a couple other questions before we are wrapping up. So I know you kind of touched on this a little bit, Katrina, but can you share with us a bit more of what a future vision with less police looks like, and how might it function? What are the right places for police presence versus community patrolling and de-escalation?
Yeah, I mean, I was just trying to type my response to this because, I think in an abolitionist frame, police is kind of out, right? And then we think about all of these different problems that have become lumped into policing as different social issues and human rights and human needs that people have. For instance, just a few days ago, the apartment where I'm staying in San Francisco, there was like somebody in the backyard, and it had been determined, there were police asking to get into the backyard to find this person who had broken in and was squatting maybe in an empty apartment nearby. And the person was handcuffed and taken away, basically. And I'm sitting here being like, wow, that was not what I want to happen, right? Like one immediate solution, or one of my reactions to this is that person is homeless or houseless or mentally ill. And so the solution to that problem is not bringing them to jail or prison, but rather having housing. And how many times, I'm not sure how many other people are healthcare providers here, but there are times where we have to, just like 2 days ago, I had to discharge somebody from the emergency room who told me if he goes outside, he has no choice, he's nowhere to go. He's gonna have to go to like, someplace, stay with other people who are drinking a lot of alcohol. Then he's gonna end up drinking a lot of alcohol, which he really doesn't want to do. There's no like immediate access to shelter beds. So like we don't have a housing situation, and that's becoming a police problem. So, I can't think of one scenario where it's better to have a police officer than to have invested and spent our budget in a different way to prevent problems, because the person who was breaking into this house did not want to be homeless themselves, right? They did not want to put themselves in that situation. If somebody's breaking into my house, you know, and we just don't live in this world right now, but we could, and with other people thinking creatively about solutions to this, I think other people could give us a better answer. But, you know, I imagine myself being like, do you need something? You know, and trying to not be afraid and trying to say, look, I don't want to get hurt, like, and I don't want you to get hurt either. And you know, then I think about gun safety. I think, why do we have so many guns? We could live in a different country where there's not as many guns, and I'm not going to be as afraid if somebody breaks into my house if they have a gun or that they would hurt me. So I think a lot about budget justice and doing budgets for equity and racial justice, and they have a lot to do with investing in things that are not police.
Thank you. And this is our final question. I think, Amy, this will be appropriate for you to respond to. Why would there be a difference in doula policy between UCSF and ZSFGH? If ZSFGH can recognize the need for doulas and expedite permitting them back on labor and delivery, why would UCSF continue to bar them? We have a shared faculty after all and practice the same standards. Why did the UCSF COVID task force delay letting doulas back in?
Yeah, it's a great question, actually, and I really appreciate that being asked. And well, respond with, this is part of the advocacy work that we were working on the UCSF side. So the system, the UCSF health system, was applying visitation policies across the entire enterprise, and changes that were happening in one area were impacting other areas in a way that were different than the ZSFG hospital, which is one entity. And this is not, I'm not actually defending when doulas were there or not there. I'm just actually stating what happened. And so it was then became the job of the Women's Health Service Line, which is actually a newly created entity to support women and women's health care at UCSF, to advocate on behalf of our patients to expand the visitation. And that, while we worked toward it to be as efficient as possible, it didn't line up exactly with the CSFG approach. And I'm not even sure that there was that much of a difference. I will say that the other area hospitals in the city were also fairly restrictive in their visitation policies, which impacted doula access also. Not to say that that's right or wrong, but it did actually take some significant advocacy on behalf of women and obstetric patients to be able to advance our visitation policies and allow doulas back in.
Thank you so much, Amy, for answering that question. We're going to go around and give our final thought. And I'm going to start with Dana. Any final thoughts or reflections you have to share?
Just that I've really enjoyed the discussion, and thanks everyone for being here. It's been really interesting, and I'm just very honored to be here. So thank you.
All right, Katrina or Amy, who wants to go next?
Oh, I'm unmuted and she just muted, so that means I'll go next. Let Katrina have the last word. I just would share Dana's sentiment that it's an honor to have been invited to be able to share my experiences and reflections from this past year, especially, and really excited to be a part of this collaboratory and continue the work.
I was just reflecting on how when I was in residency, I learned about the progesterone injection for preventing preterm labor or deliveries. And somebody had done a quality improvement study at my hospital in Boston to say that Black women were not being offered this at the same rates as non-Black women, and for a multitude of reasons, including some racism probably in the original research that said it didn't help Black women as much. And I think about, well, people need to be offered treatment at the same rates to potentially benefit from a potentially helpful thing. But at the same time, the research that Dina is presenting today is showing us that the treatment is actually less exposure to police violence. And thinking about that as part of our work is really important. And so I do invite anybody to come to the DPHMustDivest meetings on Wednesday. Feel free to email me or follow us on Instagram. And thank you very much for allowing me to represent this amazing organization and the work of so many people in the community and at the General.
Well, thank you so much to all of our great panelists. And again, I want to lift up our advocates who are not in the space today: Asmara, Andrea Jackson, Ana Delgado, Tiana. Thank you so much for everything that you do. And just thank you to our audience for all of your great questions and for joining our July Collaboratory. We hope that you will join us next month for our August Collaboratory entitled Police Brutality's Impact on Black and Brown Mental Health. You can RSVP at bit.ly/police impact, which is also posted in the chat. And finally, we want to spotlight again our organizational highlight. Cameo House is a long-term transitional and alternative sentencing program for homeless, formerly incarcerated women and children in San Francisco. The program provides on-site case management, a safe and stable living, and an array of services. If you want to learn more, you can go to bit.ly/Cameo House info. And if you'd like to contribute to their mission, you can do so at bit.ly/donate-cameo. Thank you everyone again, and for this really powerful conversation. And just want to remind folks that we will be closing the Zoom link in 30 seconds, and we hope you have a great rest of your night. Thank you so much.
I hope you make it home. I hope you make